Uh, Good afternoon, Larimer County. Welcome to our January 17th, 2024 work session. Our topic today is to learn more about the Community Master Plan 2.0 regarding behavioral health, to get an update on the work that's been involved with updating our master plan and having a good discussion about that. My name is John Kafalis, Larimer County Commissioner from District 1, joined by my Commissioner colleagues, Kristen Stevens from number 2, and Jody Shattuck McNally from District number 3. And of course, we serve the entire Larimer County to the best of our abilities. We are also joined by our Assistant County Manager, Lori Kadrich, who is serving as the acting county manager while Lorinda is away taking care of family matters. And at this time, I will check in with Lori to see if there's anything you'd like to say to cue this up, and then we'll turn it over to our friends on the other side of the table.
The only thing that I'd like to say, Commissioners, is I want to thank Laura Walker for serving as the Interim Director for Behavioral Health Services and shepherding the opening of our new facility, the Longview campus, doing that work in addition to her other duties, and then as well updating this new master plan and preparing for the next phases for the development of the campus. And I really appreciate the work that you've done, Laura, and absolutely the experience that you brought to the table in getting these things going.
Wonderful. Thank you, Lori. And we'll turn it over to Laura Walker. Again, if you folks would be kind enough to identify yourself for the record, and we'll proceed.
Thank you, Commissioners, and thank you, Lori, for those kind words. It's really been a privilege, actually, to have served more directly in this role. Behavioral health services has always been a part of my service area as the Human and Economic Health Director for the county. However, I was always a step removed from the day-to-day operations, and with so many momentous occasions happening with that department and the opening of our acute care facility at the Longview campus, it's been really a great experience, even if it was a heavy lift. So thank you for that. So I have with me today Taylor Kelly from our Behavioral Health Services Department, who was the project manager to have the second iteration of our Community Master Plan done this year. Actually, it was in 2023, excuse me. And then we have Summon Mother from the Colorado Health Institute here to present their work because they were the delivery agents to do the analysis and the data gathering to create this report. So I actually, though, would like to start with just a little history, and not so much because the commissioners, I think, are not aware of how we got to where we are today, but because this is a public meeting, I just wanted to kind of bring folks up to speed and give some context about why we're here today. So if you recall, in 2018, we had a successful passage of a ballot initiative for a 0.25% sales tax countywide that was dedicated to filling gaps in our behavioral health services system here in the county. And in preparation for that 2018 ballot initiative being put out there, we did have a community master plan that was done with external help and a lot of community partners coming to the table to make sure that we had really good factual basis for why this tax was so necessary and where the gaps in the system existed and what recommendations our community and these experts would have for the utilization of these funds as they started to come in. So that was Community Master Plan 1.0. I know Commissioner Kafalis referenced this is 2.0, and that's correct. So this is a 20-year tax that was established, and we determined early on that we would have 4 phases within that 20-year time frame until such time as the ballot question may come up again. And so phase 1 was really guided by that initial Community Master Plan 1.0. And a lot has changed since then. We had a pandemic. We've had some very significant changes in the data that we're seeing around social isolation, suicidal ideation at our health providers, especially around young people. And so the landscape is different. And we knew that as we moved through the 4 phases, we would probably need to revisit that original document, which I think was 270 pages. I know Commissioner Shattuck McNally carried a bunch of them around in her car for 2 years, and they were heavy documents. So then we get into 2019. We then established the Behavioral Health Services Department as a county service group within the county. And we began our grant program, which was to get immediate relief into the community for those behavioral health needs that may be served later on as we were building out the Longview campus, but certainly we had providers in our community looking to expand services and develop new services, and so we made those grants available in 2019.
Pardon the interruption. I'm wondering, the screen that we're seeing here, we're not seeing it broadcast. Do we normally put the slides so that folks can see this if they're watching? Cassidy, who does that?
Yes, I do have the input with the slide on it.
Well, it's very nice to see images of our Human and Economic Health Service Area Director. I think this would be better. Thank you.
No problem.
Thank you. Please continue.
Oh, certainly. So we had the first round of grants in 2019. Those have continued annually since that time with varying amounts of resources being put towards the grant opportunities. We're up to $2.8 million in grants being offered out to the community. This year was particularly difficult decision-making in allocating those $2.8 million because we had more than twice that in requests from our community, which on the one hand, it's encouraging to know that the word is getting out, basically, that the Behavioral Health Services Department has these resources and that we're here to help. However, not being able to fill more than half of the requests that came in was discouraging as well because every proposal had benefits to it and certainly would have helped some folks in our community that aren't getting helped otherwise. So at this point, the facility did open on December 2nd. So we had a 3-year window of a flurry of architecture activity and planning and development and construction. I know all of our commissioners have had the opportunity at different points to see the facility and have been able to take tours, and the operations are going swimmingly at this point. I was just sharing with Commissioner Kafalas yesterday that the acute care facility being operated by Summit Stone Health Partners started their work with 16 residential beds, which were intended for crisis stabilization. And they've now added another 8 beds for withdrawal management. So we're up to 24 beds plus the urgent care and the up to 23 hours of observation areas within the facility. And we've been at pretty much 90% plus filled for all of the lines of service since we opened in December. So the needs are getting met, but they're still there, and I think we still have more to do. So from there, I think I'll pass it on to Taylor to let you know how the information that we've gathered in 2023 for this project should be taking us into the future and be addressing those other needs as appropriate. Thanks.
Thank you, Laura. Welcome, Taylor.
Hello, thank you. My name is Taylor Kelly. I serve as the implementation manager for Behavioral Health Services Department. Excited to be with you today to present the second iteration of the Community Master Plan. We've had a bit of a pivot in how we're presenting to you today. I wasn't planning on speaking, but Summon's colleague Chrissy got sick this morning, so you'll be hearing from me as well today, so just bear with us as we kind of do this on the fly. But I'll let Summon introduce herself and take it away from here.
Great. Yeah, thank you, everyone, and thanks for having us. My name is Suman Mather. I'm a director at the Colorado Health Institute. I actually am also a Larimer County resident. I've lived here for about 7 years and spent about 5 of those years working at the Health District in Northern Larimer County, actually with Taylor. And so have, sort of followed along this journey for, since the beginning as well. So I'm really glad to be able to work on this from the other side. I also just want to note a few of my other colleagues who worked on this community master plan, Chrissy Esposito, who's a senior policy analyst at the Colorado Health Institute and the lead author of this report, and also Allie Morgan, who was formerly a director at the Colorado Health Institute and is now the policy director at the Colorado Association of Local Public Health Organizations, and is actually a lifelong Fort Collins resident herself, now lives in Denver, but her family is still up here. So for all of us, we have ties to the community, and we're really grateful to be part of this process. So our plan for today is that I want to start off by reviewing a bit about the project background, and then Taylor and I are going to sort of tag team sharing out the recommendations that came forth in this report. There are a number of recommendations, so we know that you will have questions and are happy to answer those as we go along. And then finally, we'll end with some next steps about what we expect to do in terms of dissemination of this report and how it might be used. So project background, I should have said earlier, Colorado Health Institute, for those of you who aren't familiar, we're a nonprofit research and consulting organization focused on equity and well-being across the state. And so we tend to take a little bit of a research-based approach to a lot of our work, including this community master plan. So we decided to go about this process in a few different phases. So first, we started with developing a research plan itself. And so we worked closely with the Behavioral Health Services team, as well as with other community stakeholders who I'll share more about here in a moment, to identify what the key questions we wanted to answer through this master plan might be. That took us into our next phase of quantitative and qualitative data collection. I will say that, one of the things that I always appreciated here in Larimer County is just the wealth of data and reporting that already exists through partners like the Larimer County Department of Health and Environment, the Health District, Northern Colorado Health Alliance, and others. So actually through that phase, a lot of the work we did was synthesizing existing data that many of our partners had been collecting over the past 5 years or so. We then went into a stakeholder feedback phase where we were able to actually talk through some of what we had learned with folks and sort of get their reflections on how we might prioritize and use that information. And then our last phase was, of course, this report drafting and finalization phase. As of now, we, of course, have the English report available to you all, and we are also wrapping up finalizing a Spanish version of the Community Master Plan as well. And I'll just say, too, that throughout all of these processes, we were, of course, guided by the Behavioral Health Services team, but also the executive sponsors, which included the county, the health district, and Summit Stone Health Partners, as well as a guidance team that supported and oversaw many of these efforts as well. Sorry. All right, so I don't want to go too deep into the methods because I know that that's not the interesting part of our presentation today, but of course we came up with our research plan and did a little bit of an analysis of data gaps that might exist. That took us into our quantitative analysis work, so we really pulled a lot of data from existing surveys. CHI runs the Colorado Health Access Survey, so we use some data that we collect ourselves. Wrapped that into a literature review that sort of summarized a lot of what we had learned from those existing data sources. I should also note that we also worked closely with the health district, who is completing their youth mental health assessment during this time, and we're taking in sort of what they were learning throughout this process. We conducted a number of key informant interviews, ran some stakeholder surveys, and then also made sure that we were checking in with experts in the community, be it through sort of technical expertise or their own lived experience. So through that process, we talked to a number of really key stakeholders in the Larimer County community. I won't read every single individual on this screen, but we certainly have immense gratitude for everyone who was willing to partake in this process. We know that there are a number of things going on in the community at this time, and we were appreciative of those who either filled out a survey or took part in a focus group or interview with our team. We were able to really get a wide variety of inputs. So before I turn it over to recommendations, I just want to note that given just the broad swath that really encompasses behavioral health, you'll notice that in these recommendations and in the report, we often refer to Larimer County as both the entity that we are part of here today, as well as the community as a whole. So many of these recommendations, we might use the terminology Larimer County, but we really are thinking about the full scope of stakeholders in this community, not just county government or behavioral health services. So I just want to make that clarification before we begin. So with that, I'll turn it over to Taylor.
Okay, so this is the fun part. I'm going to go through we have 14 prioritized recommendations ultimately that came from all of the hard work that CHI did with data collection. And these are broken down into 3 different areas. The first being building on the progress from the 2018 Community Master Plan. So that's the first section that these, I think, next 6 recommendations fall under. The first one being to evaluate and continuously look at how we are effectively leveraging this funding, the sales tax and use dollars, into our new acute care facility on the Longview campus. So making sure we're looking at service utilization, exactly who is using it, why they're using it, and what gaps and challenges continue to arise from operating a new level of service here in the county. Our second recommendation is to really look at aligning and collaborating with our agencies. As someone was saying, when they were going out looking at all the different data that was being collected, we did a lot of realizing that several different agencies were asking the same questions of the same populations, and really just hammered in this point of doing some better collaboration with each other on what data is being gathered and how we can be better stewards and sharers of that information. Otherwise, we're really running the risk of survey fatigue and overburdening specific populations by continuously asking them their experiences in the behavioral health system. Okay. The third recommendation, as we're all aware, our youth mental health outcomes are continuously getting worse throughout the county and throughout the nation. So no surprise that youth services specifically came up as a recommendation from this report. But one of the things that we felt necessary to better understand was to really do a feasibility study in our area to understand what the actual demand and need is for the types of services that may come to the Longview campus if we were to build another building. What exactly do those services look like, and what would add the most benefit to our community, and what already exists and is lacking? So that's the third recommendation, is to really dive into that a bit more into detail in deciding the types of services needed. The fourth recommendation, this was the topic of care coordination, was a very important one in the first community master plan. I think it really laid the groundwork for many different programs and agencies that have started doing care coordination throughout our county and even the region, thinking about COAST law, Colorado opioid synergy for Larimer and Weld. The most terrible name. But this effort of care coordination is really been built up, and we have a lot of folks who have built teams to do this work. But what often the stakeholders said, our providers in the area are saying, is that there continues to be no centralized referral hub, and making referrals continues to be fragmented and can cause harm to the client themselves if they have to repetitively offer the same information in different spaces and places. The fifth recommendation was to continue to expand proven programs for addressing acute mental health needs and substance use crises. I think, we've all seen the growth of co-response in our area as a really effective program for diverting folks away from jails and emergency departments. And we do see that as a success since the first iteration of this plan, but it can continue to be built upon as our jails and emergency departments are still the sort of the go-to for where we're bringing folks in that level of need. And obviously, Longview, our acute care facility, is prepped to respond to that need as well. But to continue to build up these different types of programs is especially important. And just a little data tidbit here, we got this information from the Larimer County Sheriff's Office and just the number of contacts and referrals by year, which I'm sure this information has been presented to you before, but you can just see the great amount of need and of course, as their team expanded to the ability to address that.
I realize that Suman said we could ask questions along the way. Before we start getting into that, we need to be done by 2:25 so we can transition to the next one. Can we have these kinds of questions now, or is it best to wait until the end? And I mean that with the greatest respect. I just want to make sure that we're not rushed at the end.
Yeah, I would say we have 14 recommendations. We're on the 5th recommendation, and we're well before 2 o'clock. I do believe it would be all right, but I certainly would be willing to look at time as we go, and if we need to hold some questions till the end if they're extensive or do them offline, I can certainly offer that.
So I'm going to exercise my facilitator prerogative, and I guess if you feel like it's absolutely necessary to ask the question now, go for it, but I'd like to suggest that we try to wait till the end so we could have that discussion. Thank you, but do you want to go ahead?
Yes, I would, Mr. Chair. I feel like it's relevant to the slide that we're on and important for information to go forward. As you know, I'm very aware of the co-responder program. We've worked on expanding it, and I hear these are the contacts mostly from the Sheriff's Department. I know, since I've been involved with this, that they've started to collect more data and doing more things. But we are also having a data subcommittee. Taylor, you're part of that with the ROAC, and we know there's data that the Fort Collins Police Department has offered all their data, and I think we're looking at getting some from Loveland, and I'm wondering if you think that would be helpful for this master plan to have some of that data be brought together for helping with this master plan, if we have a kind of indication of what's happening in all the co-responder programs.
I'm quickly looking at some, and I can't remember if we got anything from Fort Collins Police specifically.
We did not receive data from them. I do think that is data that, to the earlier recommendation in terms of having some, coordination of these different data sources. Like, I think that this is an example where people are really interested in co-responder programs and want to sort of see the impact of that program throughout the community. So maybe not necessarily for this document, but I think going forward, like having some organization around, summing up those data would be useful to, further understand the impacts of the co-responder program.
Thank you.
Yeah.
Thank you for that question. All right. The sixth recommendation for this plan was to continuously modify and evaluate the Impact Fund grant program and the application criteria and award process. That's something our department already does on an annual basis, but continually to look at what the community need is and adjusting to certain crises that may come up, like COVID as an example. I think our department pivoted pretty quickly there to support behavioral health needs. But another thing specifically that came up from this project as a recommendation was to launch into potentially multi-year funding. We've heard continuously from partners that one-year grants aren't very sustainable for them, and it's hard for them to make significant progress and really drive those high-level outcomes on a one-year basis. And then the last recommendation for this area is to think about how we can be better stewards of this community master plan in general. One of the recommendations that was made was to have the guidance team and executive sponsors meet on an annual basis to sort of document progress and celebrate wins and talk through different challenges and how it's being addressed throughout the community, and just keeping a general tab on how we're addressing the needs in the community based on this plan.
Thanks, Taylor. Now we're going to move into our section specifically around behavioral health services and support. So these are specific programs or program types that we wanted to call out in these recommendations. The first being adult-focused programs, which I realize is sort of like awkward wording when you hear that first off. But one thing that we heard consistently from our conversations is that while a focus and emphasis on youth is needed, it shouldn't be at sort of the disservice or the loss of other population and ages. So we actually have data that shows that there are some really high-risk behavioral health outcomes happening with groups who are sort of outside of that typical youth age group, right? So these are suicide rates per 100,000 by age group. And you can see here that if we look at the ages between 25 to 34, as well as adults age 45 plus, we're seeing increases in both sort of time as well as just some really honestly concerningly high rates of suicide. Another thing that we heard through some of our conversations with direct service providers was sort of this missing focus on older adults. So specifically during the pandemic, we heard from a number of providers who said that they were starting to see members of the populations ages 75 plus coming forward with more mental health concerns and wanting to seek help and services. And we also are seeing data, you can see that here in this data around suicide rates, with concern for some of those older age groups that I think we have maybe previously overlooked in terms of mental health services and supports. Another area where this is really profound is when it comes to alcohol use. I think it's probably no secret that in Colorado, alcohol use is a concern, and that is true here in Larimer County, right? We have some cultural norms and things in place in our communities here in Colorado that make this a concern. So when we look at adults who reported binge drinking, we find that nearly 1 in 5 report doing so in the past month. Nearly a third of fatal car crashes have involved alcohol, even though we generally find that the rate of people who report that they've driven after drinking is fairly low. The data shows that even if it is a small percent, it's having profound impact. And then, of course, we also are seeing that with our younger populations, high school age students, there is high rates of binge drinking happening as well. But this is sort of an issue across the board. And I'll also note that though this is not Colorado-specific data, nationally, most alcohol poisoning deaths are among adults between the ages of 35 to 64, highlighting the need for substance use and mental health prevention and treatment programs that extend into adulthood. But of course, youth-focused programs are crucial too. So circling back to youth, before we discussed the need for, earlier we discussed the need for some additional research around the types of acuity and sort of the types of services that are necessary for youth in a potential new facility. But this recommendation is really about expanding existing services and those services needing additional investments so that they're tailored to the appropriate populations. So here's some data here that sort of, again, highlights the, again, really concerning need that we're seeing amongst high school age students here in Colorado. And what this data is not reflecting, but is reflected in other portions of the report, is how this varies by specific members of the community, including LGBTQ plus youth, youth of color, et cetera. And this recommendation is around really making sure that there are additional investments to assure that those with the highest needs are addressed. And I'll also call out, I think something that came up quite a bit was amongst mental health for our youngest youth, right? So infants and young children, ages 0 through 5, we know that's a crucial period. And again, a crucial period for mental health as well. Okay, moving on to recommendation 10 around workforce. I think in nearly every single one of the conversations that I had with someone in this community, workforce came up. And specifically around, in order to address many of these challenges or to really implement many of these recommendations, there needs to be some attention given to workforce supports. So again, really, if we're thinking about specific members of the community, not only are we, I think lacking in terms of volume of workforce, but if we're thinking about, again, communities of color, LGBTQ plus communities, communities where mental health supports might be more stigmatized, it's really crucial that there's a workforce that's able to sort of represent and speak to those community members as well. And I'll note that workforce, of course, includes sort of our more traditional direct service providers, therapists, physicians, et cetera, but we also heard a lot around peer supports and maybe folks who are in roles that are more appealing to people who are a little more reluctant or have faced stigma in the past in terms of receiving services. And that, of course, corresponds with this recommendation of investment in community-based organizations and initiatives that serve populations with unique behavioral health needs, specifically thinking about rural communities, LGBTQ plus individuals, unhoused people, individuals earning low incomes, and historically marginalized racial, and ethnic groups. We know that many of the community-based organizations here in Larimer County are already doing really important work here and have earned the trust of many of those communities. And so the recommendation here is to really think about how further investment and supports to those existing groups that have this relationship can be built upon. Okay, with that, I'll turn it back over to Taylor.
Okay, our last few recommendations lie in this upstream preventative space. It would be hard to talk about behavioral health without talking about prevention, as we've been talking about more of the traditional treatment options. No surprise here that affordable housing came up as a major concern with all the providers that we were talking to. It's really that foundational pillar of our health, and people experiencing housing instability have increased risk of poor physical and mental health outcomes. I think it's something that is a system level issue, but it is not. It doesn't not show up in conversations for providers when they're working with their clients. It is often a major barrier for them to access mental health and substance use care. And just a couple data points here, and I'm sure you've heard these before, but in Larimer County, 1 in 3 residents are housing cost burdened, so paying more than a third of their income towards rent, and 2 in 3 renters aspire to own a home but feel that they are unlikely to. The 13th recommendation that came up was really about addressing the isolation and loneliness epidemic that has really taken over both in our area and I think nationally as well. Connection with your community is a key component for mental health, and especially for folks in that recovery space too. And if I'm sure you all have been following along, this very closely aligns with our friends over at the health department in their community health improvement plan. This is one of the priorities that they have, as well as building out more opportunities for pro-social connection and opportunity for gathering and building that community. The last recommendation is to really continue to evolve our awareness campaigns to further reduce stigma when it comes to mental health and substance use. I believe we've made significant progress in this area the last 5 years, and we have many partners in the area who are working on this and continue to see this as a challenge in specific populations. And when it comes with stigma, I think we believe that the work is never done. So we can continuously make sure we're addressing that challenge for folks.
So we had our 14 recommendations, but we really could have had many more. And the 11 additional challenges that are listed here on this page are additional challenges that were identified in CHI's initial assessment, but were ultimately not included as prioritized recommendations. That's not to downplay the importance of these 11 topics, but many of them are sort of systemic challenges that we felt were not quite appropriate for the axis of control that this community master plan had. And we still included them in the document, though, to note that these are things that are of interest and of importance to the community and will likely require coordination, at a state level, national level to really address fully. So things like cost of care, insurance, food access, affordable childcare, and things as broad as systemic racism, discrimination, and unfair treatment. So, of course, important things to note, but we don't have active recommendations related to these. So with that, we know that those are a number of recommendations, and many of which are actually a combination of multiple recommendations. So I'll turn it back over to the Behavioral Health Services team to share more about next steps.
So with this new community master plan, our intention as a department is to first present this to our consumer advisory committee and technical advisory committees to use this information and the data that we've shared today to inform how we create the targeted projects for our Impact Fund grant program in 2024. So we'll be heading into a session with them and starting next week to work on this, and we'll bring that forward to you in a few months from now. Of course, we'll be disseminating this to partners for their own use. And then Laura and I have also committed to a little tour day municipalities, and we'll be taking this information to a few different town hall meetings, city council meetings to present as well. And then, of course, the team in the Behavioral Health Services Department will largely be using this document as guidance for how to continue forward for the next 5 years until another one comes out. So. With that, I think we've got time for questions. And
First of all, thank you, thank you both, all three of you, very much for your presentation. And it looks like we have a good amount of time for conversation. It looks like Commissioner Shattuck McNally has her hand up. Please.
Thank you, Mr. Chair. This is my second time hearing this. I want to thank you for your presentation. This is a little more in depth, so I appreciate the extra information. And I go back, I think these are recommendations that are kind of, I think I said this before and I'm saying this for the public, but some of these are carried forward from our first 1.0 Community Master Plan. So my first question is, as we look at the ballot language and what we can do with behavioral health services, the upstream, recommendation number 12, affordable housing, is it the recommendation that somehow we have behavioral health services get involved in housing, or is it just to call attention that we all need to kind of engage in helping with housing? I'm kind of trying to wrap how that would, because if these are recommendations they're going to TAC, are we going to be making a recommendation that impact grants help with housing? Or, I mean, I'm trying to understand how this fits into that process, and then I have another question about the feasibility study.
Okay. So the utilization of any of those sales tax funds that come through the Behavioral Health Services Department will always be guided in a legal way by the ballot language that was presented to the voters. And so any of the activities that you see here that have been recommended, we will be very careful about where the funding sources come from that. And it's to acknowledge that that is an issue that has a direct impact on folks' behavioral health status. And so it's really an acknowledgement for more of those, as Simon said, the more community-wide responsibilities that lend themselves to improving behavioral health community-wide.
Thank you. And I think that's what I understood. I just wanted to kind of say that for the public, because I do think it is important, an important factor that's happening in our community, along with social connection and loneliness. And my second question is, and Laura, I haven't had a chance to follow up with you on this because our other conversation was important to take a priority for timing-wise, to the feasibility study. As you know, working on this project for over almost 8 years now or more, this youth need is not new, and it's probably exacerbated, grown and gotten worse. So when we talk about this feasibility study, we know phase two is going to build a building. Is this feasibility study going to have to happen before we continue to make progress forward, or what do you talk about a study? Because the study could take a long time, or is this a short period? And I'm wondering how that fits in because, we were looking at, if we had gotten that grant from the state, we would be probably breaking ground or doing some things. And I know it's great that we have this pause and we're trying to evaluate really what we need, but I hear from families for years now the desperate need for some more services, more things, and so I'm feeling the urgency that we needed to have something else or in place yesterday. So I'm curious about that.
Yeah, so I would say that for the acute care facility, the amount of data and analysis that was put into what are the necessary services and have those in a prioritized list so that as we open the facility, the most important ones came first. And then as we expand the services within that building and use more of the square footage, that we're getting to the next and next priorities of what the greatest needs were. That was a very data-rich exercise. We don't have that kind of data for youth utilization. And part of the issue there, and it's even been admitted to me, I hope I don't get in trouble for this, but our friends at the Health District of Northern Larimer County, who just finished their youth assessment, they acknowledge too that it's weak on specific utilization data of specific services for youth. It is very rich with anecdotal information, and those stories are very difficult to hear, and they're extreme, and they are catastrophic for families and the youth to whom they are happening. However, the data is still shallow. And so making a little bit better effort towards that before we would establish services is something I think is important. And I don't know, Suman, if you have anything more to say, since this was a recommendation that came out of your research, if there's anything more to add to that.
No, I think that's right. I think we have a lot of data around outcomes for youth and sort of like what the current state is. But yeah, it's that utilization data that is just really hard to get. And youth data generally is just lacking at such a granular level. And I think before, again, for the acute care facility, there was a lot of rich data that showed these are the exact services. This is, what we expect the demand to be. And we just weren't able to find data that suggested that yet for youth, not to say that the need isn't there.
Great, and if I could just clarify on that, the youth data survey that was done, that was the one that was requested out of the Youth Mental Health Task Force?
Correct.
Okay, that's the one we had that meeting, okay.
Yes.
I think that's all I have right now. I do have more, but I want to give my colleagues a chance. Thank you.
Thank you, Commissioner. Commissioner Stevens, do you have questions, comments, observations?
I certainly do. Thank you, Mr. Chair. Well, thank you, Suman and Taylor and Laura for your work here. I'll first build off some of the questions that Commissioner Shattuck McNally was asking. So when we're talking about youth utilization, we're saying that while youth need services, we're not exactly sure that they might need 30-day bed services or particular services, right? We know they need services, but we're just not sure at what level and
I think even more so the volume. So I think we could make pretty educated guesses towards the types of services that are the best interventions for youth versus maybe an adult population. What is really lacking is the demand. And we had very clear trajectories for what kind of demand we thought the acute care facility was going to need to accommodate if it was really going to try to get closer to solving the problem. That's what's missing, and a lot of it is because people under the age of 18, the information about them getting served in the medical or behavioral health systems is not as available to us as it is for adults. And also because some families have had to send kids to different locations, it's really difficult to look locally to say which Larimer County kids got these kinds of services, because in many cases, and I even know in the child welfare system, when we have custody of a child, if they need a very specialized high level of care, many times we have to send them even out of state. And so looking at what's being provided within our community is not as helpful for that youth population as it is for adults either.
Right, and I would imagine that in some cases, I mean, we can't provide every single service that might be needed. So some of the cases might be, the acuity might be so severe that we have to, I mean, I don't know. I'm not saying we don't want to serve kids in our community, but some kids need specialized care that maybe we wouldn't be able to provide in a facility like that. Is that, okay. Just trying to get a handle on that. So I guess that's a space where we need to really dig deeper and try to, I mean, is the data out there, or do we need to start collecting more data? And
So I've been toying with this idea and haven't really fleshed it out through my chain of supervision just yet. But I do think in the same way that it was worth a financial investment for Behavioral Health Services Department to fund a 2.0 version of this, I do think that there is a reasonable expectation that we should be able to fund a more youth-focused study. I think the challenge is going to be finding a vendor that can do that. But until we put an RFP out and ask for that service to be filled, we are kind of in a gray area. So I do think I'm going to bring forward the proposal that we might do that in 2024 so that we can get moving on that. And maybe there is a vendor somewhere out there that can give us what we need.
yeah, thank you. It just obviously makes sense to do that before we build anything, to make sure what we really need to build and what kind of services we need to offer. So I appreciate understanding that a little bit better. Well, one of the questions was on we have no centralized referral hub. Right now, is our behavioral health facility able to sort of fill that role, or are we looking for like a separate organization who can do that?
While I think that Summit Stone Health Partners as an entity might have the capacity and the reach across the county geographically to provide that kind of a service, it's not carved out as a specific service that they have resources to fund on an ongoing basis. Their care coordination and those type of things is very client-centered, so it's the person in front of them at that moment. We do have an enhanced care coordination function at the acute care facility, but keep in mind that the people that are touching the acute care facility are in a self-defined behavioral health crisis, and this care coordination or this connection to services should be for anybody on the spectrum of behavioral health needs, not necessarily all the way to the point of crisis care.
Okay, so it's not been determined what that exactly looks like, but we know we need it. Is that correct? Would that be fair to say?
Yeah, I would just add a lot of the conversations with providers, they were speaking towards, I think a lot of this comes from that data sharing piece as well as, one person who's seen by Summit Stone is also touching potentially like 9 different organizations in one day. So there's issues in even at the care coordination level where folks are having a difficult time getting that person from one place to another because the systems don't speak to each other. They're speaking different languages, and of course getting a release of information on the spot it constantly adds more barriers to doing that work. So that's where the referral hub kind of came from, was like a sort of centralized space where there's one ROI everybody signs on to, and they can coordinate much easier across systems.
Great.
Sorry.
Oh, no, please go ahead.
I'll also just add that, another thing that came up in conversations is the state's investment in the social health information exchange infrastructure, which is sort of the back end of being able to share a lot of data and information about patients, specifically with regards to social needs and social determinants. But as that work is sort of happening at the state level, I think that'll tie neatly into this recommendation and, how that looks in terms of implementation within a county.
Great. Yeah, no, it makes sense, and we don't want people duplicating efforts, or and as you touched on earlier, not duplicating these surveys, which we're asking the same people to take over again. So I think the more we can coordinate this, the better. Just a couple little more things. With affordable housing, did the ballot language at all allow for something like permanent supportive housing? In other words, very specialized housing that would address mental health needs?
The way that I would interpret that, and I would certainly rely on our county attorneys for interpretation before we would move forward with anything that's not clearly defined in the ballot language, but I would say provision of services for mental health support within a permanent supportive housing group of units might be something that could be supported, but like the building of, or like the building maintenance of, probably would not be.
Okay, but that would be a piece where we could partner with, the local, our housing authority or, housing
Yeah,
catalyst.
we actually have, there have been impact grant funds for Housing Catalyst to do that very thing at one of the permanent supportive housing sites that they run. So yes, we've done it before.
Awesome, thank you. And then I would just say there again, thank you for all the work. I appreciate the upstream prevention and the additional challenges. I take that as my to-do list. Honestly, like this is stuff that we know we need to work on: housing, childcare, maybe not Medicaid reimbursement rates, but we can advocate, if the things that we can't do locally, we can also advocate for. So I'm glad to have that information to know what's important to the community. So thanks very much. Really informative.
Thanks, Commissioner. I would like to ask a couple of questions and offer some comments. First of all, just to kind of continue the thread around youth services and utilization data, to kind of reinforce what I heard from my colleagues, what are our expectations around doing some type of utilization study that might help inform the specific kinds of services that youth might need in volumes and that sort of thing? We talk about 6 months, next year. What are we talking about?
I would love to see it done this calendar year.
So that's our plan,
That's my hope, yes.
and you'll be able to come back with us in a couple of months and let us know if we have a plan to get that done.
I think that's safe to say. Again, I haven't consulted with my leadership above me on this yet.
Yes, but I think you're hearing from the three of us that this is important, but we also need to understand what the data tells us.
Yeah.
And then, if I may, along those lines, a couple of other thoughts related to data sources, perhaps upstream and all that. One is, are we gathering data? Are we that might be help inform our recommendations and our decision making from sources like Safe to Tell, for example. Secondly, in a meeting a while back, one of the things I learned is that in the schools, they're often either with peer support or SROs, school resource officers. There are interactions, encounters that they track, but I'm not sure if our folks are tracking. And I mentioned that to our public health director, and I never really heard back whether or not that's information that we should be discussing with the school district to see if that's helpful information. In other words, kids that are in a crisis situation, they're dealing with internal resources, whether it's SROs or mental health folks, and somehow they keep a record of that, but is that information that we're gathering? So I wanted to put that out there for folks who are interested in gathering data upstream, because I think that might be telling if there were attempted suicides, and maybe that's something we're missing. And then regarding the updated community health assessment survey that Health Institute will be releasing on February 15th, is it your expectation, Suman, that information from that will help further inform some of these recommendations that we're talking about?
Yeah, and so Commissioner Gonzalez is referring to the Colorado Health Access Survey, which was commissioned by CHI in the 2023 year, which is being released next month. And we do have a number of behavioral health data indicators in that survey. So certainly we'll be working with our county partners to provide regional level data as that's available.
Okay, and then just one last thing. There may not be time to address this, and there may be other questions. And that is going back to the participating stakeholder page, and I don't know if that's an all-inclusive list of folks, but I appreciate the detailed discussion regarding the intersection of social determinants and these issues that we all care about. So I think that's a really good thing. What I didn't see on the list and what I didn't hear as much emphasis as I think merits, for example, the intersection of people with intellectual and developmental disabilities and behavioral health, I didn't see any reference to food insecurity. I mean, housing is the big kahuna that a lot of people struggle with. But I think in general, financial stress is the thing that really affects all of us, frankly. So I'm wondering about that. There was some reference to older adults or seniors, but I don't see, for example, Larimer County Human Services and our Office on Aging, and I suspect we consulted with them. I don't see Foothills Gateway or the Arc of Larimer County on here. I don't see any reference to veterans. And finally, and thank you for listening, rural behavioral health needs. We know it's very unique and it's very intense. Farmers and ranchers are completing suicide. They're struggling. So I know that's a big pile of stuff, but any like wisdom that you could share that we're looking at that and we'll further develop that?
I will say that the guidance team and executive sponsor participants who were part of this process are not fully included in this list. On the full report that I gave in your packet, there's a full page of every single human.
Are we addressing those social determinants?
Yeah.
Rural healthcare needs, farmers and ranchers. I mean, are we mindful of that?
Yeah, absolutely. I think that was something that we spoke a lot about during this process. And as far as older adults go, we did have representation from Office on Aging just in guidance team. But I think what I see as a struggle is we don't really have providers yet in those rural spaces who can fully speak and have that trust built with the community. So I think that was something that was slightly lacking, but I will say, and someone can fill in, but when we talked to our different providers and stakeholders, I think they all mentioned this need for more expansion into rural areas and how they can support folks more.
So I appreciate that, Keller. I don't think we have time to get into it. It's 3 minutes left. I don't know, Commissioner Shattuck McNally, if you'd like to make any closing comments. I really would like to be done before 2:30, so we could at least stand up before we start the next one.
Suman and Taylor and Laura, I just want to thank everyone and thank everyone on this extensive list of folks who participate in this master plan. I think there's some lots of great recommendations here, and I just appreciate you being here today and the partnership and collaboration. I think this is really important work to use going forward. I think our previous master plan proved to be very instrumental with where we're at and today, and obviously the need and the amount of folks and the volume happening at our Longview campus already is just tremendous and eye-opening. So I think I just want to thank you all for being here today. I've been really reflecting on this since we had this presented at the Policy Council, Behavioral Health Policy Council, and I'm continuing to have some questions, and I just want to thank you all for the work. As you know, this is important work for me, and I'm just really grateful for the folks who've dived deep into this and seeing what we can do together, and I appreciate the partnership, so thank you.
And I would just respectfully, this work is important to all of us. I want to make that clear. And also, this information that you just shared with us, is it posted online? Is it on our website? How can regular folks look at these slides? How can regular folks look at the detailed report and this a lovely little executive summary?
We were waiting to bring it to you all first to post it on our website. So we will make sure to do that and get that information for you if you'd like to distribute.
Thank you. Well done. Appreciate very much your hard work. At 2:29, we're adjourned.